oncology, close to my heart also. So we have Dr. Samarjeet S. Guman, and the moderator for this session would be Dr. Neerad Mehta. And our special chairperson for today is Dr. Sanjeev Joshi. So, Dr. Sanjeev Joshi is a director of Chirayu Criticare and Joshi Children's Hospital, Yavatmal, Maharashtra. He is an executive board member, Central IAP 2024. He has also been chairperson of election of 2024 AOP Neurology. He has been ex-national secretary of AOP Neurology, president, Vidarbha president, pediatric chief organizing chairman for Vidarbha Pedicon 2023. He is a visiting fellow to Australia and UK. He has special interest in uro-intensive care, urology. He is an IAP ex-president, IAP Yavatmal branch, and he's a national faculty of Pedicon, Neocon, Neuropedicon. Welcome, sir. It's our pleasure, utmost pleasure, to have you a part of this faculty lecture today. Over to Sanjeev, sir.
So, very good evening to all, and I extend a warm welcome, really a warm welcome, because my demography is almost reading more than 40 plus every day. So, warm welcome on this virtual platform, and I express my sincere thanks to ICH Sir Gangaram Institute, and also AOP Delhi, Dr. Alok Bhandari sir, Dr. Mukesh, uh, uh, respected Anupam sir, my colleague and dear friend Dr. Lalit, today's moderator, the ex-service person Dr. Mehta sir, and the faculty himself, Dr. Samar. So it has been a great privilege and honor to share this virtual platform with all these eminent faculties, and especially Anupam sir, who is always our mentor since our early days of IAP. And otherwise also radio diagnosis is very close to my heart, because I'm a father of a radiologist, budding radiologist. Yeah. So we all know ICH is one of the premier institute in India, not in North only, but pan India. It has got a special recognition. Most of the graduates, they seek their some or other super specialty training from Gangaram, and I really salute to this premier institute. Today's talk is about the CT and MRI in pediatric oncology. We all know that the most evolving branch in medicine today is the is imaging, different imaging modalities in the field of radiology. And we are blessed with one of the eminent consultant in radio diagnosis from the Hinduja Hospital, Mumbai. He is none other than Lieutenant Colonel Dr. Neerad Mehta, an alumnus of AFMC. He post-graduated from INSS Ashwini, and he has also served in Apollo Chennai as well, and now at Hinduja Mumbai. So over to you, sir. Again, I express my sincere thanks to AOP Delhi and ICH. Over to you, sir, Mehta sir. Sir, unmute yourself. Unmute yourself.
Thank you everyone for such a warm welcome. I'm really looking forward to hearing this very interesting subject, and very, very relevant today, because pediatric imaging has always been a challenge, particularly in MRI, because of the motion involved and the necessity to sedate the child or to have the child under anesthesia. So it poses its own particular challenge, which need to be addressed adequately. And of course, CT has its limitation in terms of radiation. So this interesting subject, an interesting toss-up between what role CT and MRI can play in pediatric oncology is of great interest and great relevance. So I really look forward to the talk, and thank you again for a very warm welcome. And thank you, Dr. Anupam in particular, who took the pains to get in touch with me after many years. Thank you, Dr. Anupam.
Sir, please introduce Dr. Samarjeet sir, Mehta sir.
What do I tell him about him? I've never had the pleasure of meeting him, but I've heard a lot about him from people, and I've seen his work and his special interest in pediatric radiology. So he has been doing stalwart work, and Gangaram, of course, has been a premier institute in radiology over many, many years. Honestly, the only time I felt a bit upset was when I heard that the number one topper in radiology entrance had chosen Gangaram over Hinduja. And I wondered quite some time why it happened. But yes, all kudos to the entire Gangaram team, Dr. Samar in particular, for the great work that he's doing. And I really look forward to learning something from his talk today.
Thank you very much, Neerad. Pleasure having you on board. And I think, Samar, can you please start off? And
Yes, sir.
Sir,
Thank you.
Bhandari
thank
sir
you
has
very
joined.
much.
Alok sir has joined.
Yeah.
So let me try and share my screen. Let's see. I'm able to- Right. So is my screen visible?
Yes, it is visible.
Yes, so thank you very much for that kind introduction, sir. On a side note, since you are from AFMC, I'm from BJ. Colleges have a long-standing relationship and rivalry. Anyway, I'll be talking about the role of CT and MRI in pediatric onco. So this, since this is not a talk on, it's not a radiology talk essay. Just hang on. This seems to, yeah. It appears to be an issue with the.
Yeah, Samar, I didn't know that you are from BJ Pune.
Yes, sir. I am actually. It seems to be stuck for the time being. Let me see what I
I'm
can do.
really scared of BJ people
Why is that, sir?
because my wife is from BJ.
Wow, that's great, sir. फिर तो sir, special relationship now.
Yeah, absolutely.
Dr. Jaya is also from BJ.
I know that. I know.
With the whom for some reason.
To just give you an aside, Mrs. Anupam also has a relationship with AFMC. Her father was one of my teachers in AFMC.
Acha,
So yes, this BJP AFMC rivalry goes back a long, long way.
Absolutely. You know, they have the same relationship which AIMS had with Safdarjung, and you know, when UCMS was in Safdarjung, they had the same kind of a relationship in 1980, 80 or so. You know, so they have the same kind of a the thing.
Yeah,
Also
I can
like-
understand.
Also like
My
Grand
brother is
Medical
from
College and
Safdarjung.
KEM.
Yes, absolutely.
Mumbai is KEM and Grand.
Yeah.
just
That rivalry was to excel over each other, sir. And fortunately, we have lot many faculties, our beloved teacher from these premier institutes in
Absolutely.
Maharashtra.
okay. Now it seems
समय
to-
अब चालू हो गया.
हाँ जी, sir.
चालू हो गया.
Right. So this is going to be a very basic lecture about how we should be using CT and MRI in pediatric onco, and what we should ask for when we are sending our patients to be imaged, and just a little bit of detail about the three most common solid tumors that we see. So the role of imaging in oncology, as all of you are aware, is basically diagnosis, staging and guiding management. And now with radiomics and artificial intelligence coming in, we are picking up a lot of stuff that the newest papers are coming in, which are actually saying that if this is the kind of imaging you've got, this is the kind of genetic alteration that will be there in this patient. So maybe even before biopsy, it gives you an idea about what that tumor is going to be like. Of course, then we follow up patients. While undergoing therapy, some patients develop complications, unfortunately. So we image those patients. And then interventions are also guided by imaging. So you have lots of options in imaging. You have plain radiography, which generally we use for chest X-rays, in limb X-rays in tumors, and sometimes abdominal X-rays for GI complaints and post-abdominal surgery. Ultrasound is the workhorse for most of pediatric imaging, including pediatric onco. For anything which you can touch, any swelling, you can do an ultrasound first, and of course the abdomen as well. CT and MRI are generally used to further evaluate a palpable lump or a visible lump or an abnormality which is seen on ultrasound. And of course, you have nuclear medicine with its own importance. So, single chest X-ray exposes to a patient about 0.1 millisieverts. This is the same amount of radiation you will get naturally over a course of 10 days, right? So this kind of chart which I have taken is an older chart where a CT of the abdomen and pelvis does 7.7. So this is 0.1, this is 7.7, this is 10 days. So it gives you the amount of radiation you would normally get over 2.5 years. And if you do it with contrast, it's about 5 years, right? But this dose has come down to less than half for us. And for a CT of the chest, which is 6.1 millisieverts in this case, we actually do this in around 1.5 to 2 millisieverts now for our pediatric patients. If anybody wants to look at further how to reduce dose, this is the website. They give you the entire protocol which you can use to do the least amount of dose in your pediatric patients. So that was the dose. What does it mean? What is the significance? As all of you are aware, most of the radiation-based studies were done after the bombs in Hiroshima and Nagasaki. And other than that, we really don't expose patients to a lot of radiation and see what happens to them. The other thing
Samar, just a moment. Mukesh, can you put your phone thing on mute? Thank you. Sir, please continue.
Yes, sir. So what does it actually mean? So this is a 2021 article in the British Journal of Radiology, which says epidemiological studies of CT scans and cancer is the state of the science. So I'm quoting that the absolute risks are likely to be small. However, because the outcomes of childhood leukemia are rare, the estimate from the UK CT study was about 1 excess cancer per 10,000 CT scans in the 10 years after exposure. So I don't think it is that relevant. If you do require to get a CT done, I think you should do it. And why would you get a CT done? I will come to that as well. This is the statement from the American Association of Physicists in Medicine, which says there is a theoretical bioeffect, and this is this policy date is from 2023 till 2028. There is a theoretical bioeffect associated with any level of radiation dose. However, at dose levels required for the vast amount of diagnostic imaging procedures, there is no conclusive epidemiological evidence to realize any deleterious effect or unequivocally predict an associated cancer incidence. The anticipated benefits to the patient from a necessary diagnostic imaging substantially outweigh any potential radiation effect. Now, the truth may be somewhere between those two statements. We try to reduce the dose as much as we can, but if you require to do a CT, please go ahead and get it done. That is the consensus. Now, what is the type of CT study? If you want to reduce the dose, another thing you want to do is you want to tailor the CT study. What do you want to look at? If you're looking at lungs for metastasis, I can tell you that on a plain CT chest. But if you want to see how are the lymph nodes in the mediastinum, are they necrotic? Are they better or worse than last time? Is there a mediastinal mass? Then we have to give contrast. Right? So when we give contrast, we may want to take a few plain cuts to see how the enhancement is going. So maybe the dose increases a little bit. Or are you suspecting, what about CT head? Are you suspecting a bleed? Are you suspecting a cortical vein thrombosis? So in both cases, I can tell you the answer on a plain scan. For solid organ tumors, what are you looking at? You don't know what the diagnosis is, or are you just following up the patient after therapy, or are you planning a complex surgical resection? In all three, I would want to do different things. If you are planning a complex surgical resection, I would like to do multi-phase images because the surgeon is going to ask me questions which I can only answer with a multi-phase imaging. So what are the surgical questions which I cannot answer from an MRI? So like Dr. Nirav said, in MRI, there are issues with motion, there are issues with spatial resolution, right? And the surgeon wants very, very specific answers from me. Which artery is involved, how much is the angle of contact, how is the vein, is the artery behind the vein, where will I find the tumor? If you look at this patient has 1, 2, 3, 4, 5 arteries extending into the liver. The segment 4 artery is actually arising from the anterior division of the right hepatic artery, which means, in simple terms, that if this patient were to have a tumor in the right lobe and the surgeon did a right hepatectomy from here, you would devitalize a portion of the left lobe as well. So the surgeons like to know these things beforehand so that the resection takes place in the least amount of time. So I recently did a case in which there was one artery which was not discussed with the surgeon probably, which was going into the tumor. And the surgeon said that it took me 1.5 hours extra just to decipher where this artery was going. So that meant 1.5 hours extra of anesthesia time for that patient. And with MRI, we find it a little difficult to give such fine details, especially as the patients are pediatric, they can't hold breath. Most of these are free breathing scans or navigator-based scans. So we have a bit of issue with that. So that is why CT comes into the picture. And what about MRI? MRI uses very strong magnetic fields, right? It uses multiple sequences. There are T1s, T2s, fat and fluid suppressed sequences. We have something called diffusion, which we use a lot. We can do non-contrast angiography with MRI. We can do the standard contrast studies, and there is no radiation. What is the issue? Issue is generally a prolonged sedation. There are movement and respiration artifacts. If you are going to give prolonged sedation, you need MRI-compatible anesthesia equipment, which everyone may or may not have. You can't use it in certain patients with implants like cochlear implants, which is a very small subset to be sure, but something to be careful about. Where do you use MRI unequivocally? Where you have no option but to use MRI. You use it in CNS imaging, head and neck imaging, pelvic imaging, and musculoskeletal imaging. Generally, we would never do CT for these patients. Where would you more or less always use CT? In lung, in patients who have an acute presentation, right? The patient is not going to be sedated and you don't want to sedate the patient. There is an acute presentation or an acute bleed. You would like to do a CT. Where can you do either? You can do either in the mediastinum, where you have solid abdominal organs, and retroperitoneal or mesenteric masses. Most of the time in these cases, our institutional practice is to do a CT. So what are the pros and cons? Radiation, intravenous contrast risks, higher spatial resolution, very fast. Now, another thing with CT is that once I acquire the data, I can manipulate the data in any field I want. With MRI, there are very few sequences which are 3D sequences, which means that once I acquire in one plane, I can make that data rotate or be reformatted in any plane. So for that, if I want to do that, I have to acquire different sequences in MRI. In CT, I just do one acquisition and I have axial, coronal, oblique, anything I want. That's very easily manipulated. And very little sedation because most of for a head scan is over in around 1.5 seconds. Abdominal scan is over in around 6 to 8 seconds. MRI can, of course, do a lot of other things which CT can't do, particularly in CNS. We can do these FA maps. We can do diffusion weighted imaging. We can do perfusion imaging. We can do arterial spin labeling. And basically, this is a patient who has a tumor in the left thalamus. And this gives the surgeon an idea about where the tracts are displaced, whether they're involved, whether they're displaced, on what side of the tumor the tracts are there. So you can go ahead and plan your surgery. Also, the extra information from MRI can predict the biological behavior of the tumors many a times. So let's look at this patient. So I will not be doing a lot of CNS discussions because that is a long topic in itself. But just look at these two patients. This is one patient. This is one patient. Do you see any imaging do you see any imaging difference? You really cannot make out what is the difference in these two. They are both fourth ventricular masses, but we have a sequence called diffusion, and look at the difference on the two. So this is bright and this is dark on the ADC maps. This is called restricted diffusion. This is facilitated. This is a pilocytic astrocytoma, which has a much better prognosis than a medulloblastoma or the embryonal tumor, which this is. So embryonal tumors tend to restrict, and just without contrast or any other thing, just based on the diffusion, I can tell you that this is more likely to be an embryonal tumor than not, and the prognosis for these two patients is vastly different. Let's look at retinoblastoma. So MRI can give you really, so this is just our 3T head coil, and you can look at the multiple retinoblastomas in both eyes. And this will tell you it's probably a hereditary retinoblastoma. You can see the optic nerve involvement, different types of optic nerve involvement. This is the optic nerve head involvement. This is the perioptic sheath. This is the scleral involvement with the retroocular, and this is what is known as a trilateral retinoblastoma when you have bilateral retinoblastomas in a suprasellar mass. And retinoblastoma, we no longer do CTs because of the genetic predisposition. So patients who have genetic predisposition syndromes, we don't like to do CT because they are very radiosensitive. Moving on to hepatic lesions. So the benign hepatic masses which we see are hemangiomas, adenomas, mesenchymal hematomas, and FNH. And primary malignant tumors include hepatoblastomas, HCCs, malignant rhabdoid tumors, undifferentiated sarcomas, and angiosarcomas. The most common lesion that we get to see in our practice is a hepatoblastoma. So we'll talk a little bit more about that. It's an embryonal cell tumor, most common primary liver malignancy of tumor. So the tumors, generally, they are very sharply demarcated from the adjacent hepatic parenchyma. They may show calcifications, they enhance heterogeneously. Both MRI and CT can be done as per institutional preference. CT chest is generally done at diagnosis as well. So if you are going to do MRI, then you have to go ahead and take the patient to CT as well. In most cases, biopsy is not mandatory in patients who have elevated serum AFP levels and when the imaging features of hepatoblastoma are certain. In case you feel that the imaging features are not matching or the age profile is not matching, you may go ahead and do a biopsy. This is what a hepatoblastoma looks like on MRI. So this is a T2 where the CSF is bright, a T1, a coronal T2, coronal T1, coronal T2, fat suppressed, and post-contrast images. So all of these have to be acquired separately in MRI, which contributes to the time. Okay? This is what a hepatoblastoma looks like on CT. So very sharply demarcated lesion, as you can see in a patient who has elevated AFP with the age group which matches. Okay, so staging of hepatic lesions, if you want, sir, I'll just spend a little bit more time on this. Otherwise, I can go ahead. This is the pretext imaging, right? It's a pre-treatment extent of tumor. So 1 to 4 based on the number of segments involved. And then if you have things like IVC involvement, portal vein involvement, extrahepatic disease, multifocality, tumor rupture, caudate lobe involvement, you keep adding these things, V, P, E, C. Those are the suffixes you can put. High risk are the pretext number 4, serum AFP less than 100 or more than 1 million, and the presence of these additional pretext criteria. So basically, how do you decide pretext? So there appears to be some confusion, particularly when the students come to discuss that how do you decide whether this is pretext 1, 2, 3, or 4? This is the middle hepatic vein. The middle hepatic vein is going to split the liver into the right and left lobes. Okay, to the right of the middle hepatic vein is the right lobe, to the left is the left lobe. So if you use these 3 veins, the right, middle, and left, you will divide the liver into 1, 2, 3, and 4 sectors. Okay, so these are 4 sectors of the liver. This one, this one, this one, and this one. So surgeons can only remove contiguous sectors. They can't remove one sector from in between. They can remove sectors from the side here and from the side here, but they can't remove one from in between here and one from in between here, right? So the tumor location. So suppose you have a tumor located right in the middle here on both sides of the middle hepatic vein. So you will have to remove how much? You will have to remove this part because it's in here. You will have to remove this part because it's in here. And this part will anyway have to come out, or this part will anyway have to come out. Why? Because you cannot just remove from in between. So a lesion which is actually small but located badly here would be a pretext 3, because 3 segments would have to come out. If luckily the lesion were located only on one side, even if this lesion was larger than this lesion, because you have to remove only one segment, that would be a pretext 1. Right? So I hope I have made this a little clear that this depends on how many segments of the liver have to be removed on surgery and not on the absolute size of the lesion. We can actually look at this patient and decide what is our pretext here. So this is the gallbladder. So that the gallbladder is also a marker between the right and left. So it is on the right of the gallbladder. That means the left lobe of the liver is not involved. Where is the middle hepatic vein? Let's see. This is the middle hepatic vein, right? So it's on both. It's on mainly to the right of the middle hepatic vein. This is the middle hepatic vein. So it is in the right lobe of the liver. Now, because it is involving the middle portion, you cannot just remove it. So this portion also comes out. So this would be a pretext 2. So this is what a real life pretext staging would look like. Now, what are the lesions that don't look like hepatoblastoma? So when you go for biopsy, if you look at this lesion, look at how low it looks. It looks almost like water, right? This kind of very low attenuation on CT, very poor enhancement. This is suggestive of rhabdoid tumors or embryonal tumors. So this was an embryonal cell sarcoma, very, very low attenuating, and you can look at the size. All hepatic lesions can be actually staged with pretext. So this was looking not like a hepatoblastoma at all. And therefore, we said that this needs a biopsy or further evaluation. Moving on to neuroblastomas, most common solid tumors of childhood. It's an embryonal tumor of the sympathetic nervous system. You can get it from the adrenals, the extraadrenal abdomen, thorax, neck, and pelvis. So the International Neuroblastoma group combines the prognostic factors, including age and metastatic disease, and image-defined risk factors to categorize disease into 4 stages: L1, L2, M, or MS. So again, IDRFs are very heavily imaging-based. They are called image-defined risk factors, right? And we will come to that just in a moment. This is what a standard neuroblastoma looks like. A very heterogeneous mass with calcifications within in the retroperitoneum. This is extra-adrenal. The adrenal is separate, and as you can see here, the kidney is displaced. So the difference between a Wilms tumor and a neuroblastoma would be that there is no claw sign here, which we will just look at in a moment. What are the IDRFs? So the IDRFs depend on where is the tumor. Is it in the neck? Is it in the cervicothoracic junction, thorax, abdomen, pelvis? Is it intraspinal? Where is the tumor, right? So if the tumor is in the neck, your IDRFs are different. The carotid artery, vertebral artery, IJV. If it is in the thorax, it is different. If it is intraspinal, you are looking at more than 1/3 of the spinal canal in the axial plane. So I'm not going to go into all of them. They are very easily available online. But basically what it means is that if any vital structure, any major nerve, any major vessel, any major airway is involved, generally it is an IDRF, because that makes resection more difficult for the surgeon. So let's look at this patient. Does this patient have an IDRF or not? So this is the superior mesenteric artery, and you can see it is surrounded by tumor on all sides. So definitely SMA involvement and encasement is an image-defined risk factor for this patient. When we were more junior, we used to get patients like this. Fortunately, not anymore, where the patient used to come to us with orbital swelling or even sutural swellings, and this was a very classical appearance, and then we used to go look for something in the abdomen. This patient actually presented just with orbital swelling. There is a soft tissue mass with the destructive kind of lesion in relation to the roof of the orbit. There are also deposits in the chest, and you see a very small suprarenal mass. This patient had a very tiny neuroblastoma in the suprarenal region. Moving on to Wilms tumor. So the mean age of diagnosis for Wilms tumor is around 44 months for unilateral and 31 months in bilateral cases. So these patients also have something called nephrogenic rests, which are a bit of a problem for radiologists. We'll talk about that a little later. So apparently there are two main ways of managing Wilms tumor between the COG and the SIOP. One of them says do an upfront nephrectomy and then look at what is happening to the staging and then decide what to do further. The other says that no, you go ahead, give chemo, and then go ahead and resect. So in our institute, I think Dr. Anupam will correct me if I'm wrong, we are somewhere in between the two. If we see that the tumor is very large and cannot be removed, we generally go ahead and give chemo and then do the resection. If we feel that the patient has a small tumor which can be easily resected, we generally go ahead and do that. So you can do both CT and MRI for Wilms tumor staging. And again, they have comparable performances. And our institutional preference is to do CT because we also do a CT chest. If you are planning to do an MRI first and then a CT, it is recommended that you do a CT first because MRI with so much of sedation will cause some basal atelectasis and you may miss basal metastasis. So this is an article in which one of our students has also contributed. And these are imaging recommendations for diagnostic staging and management of pediatric solid tumors. You can use this as a template. Like I said, we don't follow this exactly, but this is one of the ways you can go ahead and do it. That if you have a large tumor or you have a tumor with perinephric SPED, intravascular tumor thrombus, significant nodes, ureteric involvement, or bilateral renal tumors, then you go ahead and do a biopsy and then do a chemotherapy. We don't necessarily do a biopsy if we feel that this patient is classical Wilms, or you can just go ahead and do a surgery if surgery is easier. So we have a sort of hybrid approach between these two. This is what a standard Wilms tumor looks like, a very low attenuating fleshy looking tumor, which is coming from the kidney. If you remember, I showed you the kidney being displaced. In this case, we have something called a claw sign, where the renal parenchyma goes on both sides of the tumor, right? This is what is known as a claw sign, and you are sure then that this is the organ of origin. So in a child who is around 3 years old, you get this claw sign, that very solid looking tumor. This is almost always a Wilms tumor. Even if you don't look at the tumor, 95% of the time, if you call it Wilms, you will be right. So what are the challenges with imaging a Wilms tumor? One is something like this, where you have a huge tumor over here. There is perinephric extension. And then you see that there is a tumor which extends into the renal vein over here. As we go up, we see tumor in the IVC. Going up further, we see tumor in the suprahepatic IVC. The tumor is in the cavoatrial junction and the tumor is in the right atrium. That's fine. Over here, same thing you can see in a single. So this, again, this has been just one acquisition. This is not taken first in the axial, then in the coronal, which you might have had to do an MR. It's one of the advantages of CT. So you can see the tumor from the left kidney going across the left renal vein into the IVC and into the right atrium. Now, the challenge with this is, if you look closely, you see that the right hepatic vein has a thrombus in it. Sorry, not a tumor thrombus. And then even one of the tributaries over here, you can see that there is thrombus extending into it. Now the surgeon wants to know that is this tumor or not? Because if tumor is going all the way into the right hepatic vein and into the liver, it's very difficult to remove. So we kind of are called on to advise whether we think this is tumor or just a bland thrombus. In this case, if you look closely, you will see that this enhancement is different from this right hepatic vein enhancement. So this is more likely to be a bland thrombus, and this patient did go ahead and get operated. This tumor This was not tumor in the right hepatic vein. It was a bland thrombus because of the obstruction in the IVC. Follow-up after chemotherapy is another thing that we do routinely. So this is the patient, this is the pre-op scan, this is the post-op scan. Sorry, pre-chemo scan, post-chemo scan. There is significant reduction in the size of the lesion. This patient actually has bilateral tumors. In bilateral tumors also, there are challenges regarding which kidney should be operated first, whether both kidneys are suitable for partial nephrectomy or not, whether there are any foci of nephroblastomatosis in the kidneys on either side. Right? So this patient has just been operated for the right kidney. There has been a partial nephrectomy from here and here. In fact, this was the one in which there was an issue with one of the vessels. And in this patient is not suitable for a partial nephrectomy on the left side because there is invasion of the collecting system of the kidney and there is tumor extending into the renal pelvis in the upper part of the ureter. So you cannot kind of resect the tumor and leave this behind because this has tumor inside it. So these are the kind of imaging questions that we are called on to answer. And we find that sometimes it's easier to answer these very tricky questions on CT. Of course, if you can go ahead and get some people, sometimes we also get very good quality images, but with MR, it's sometimes I think a bit of a lottery. And CT, if you have a good protocol, most of the time you're able to get decent images. And anyway, if you're going to give radiotherapy to the patient later on, I mean, one CT is not really going to make that much of a difference. Just a word about nephrogenic rests. So they can either be perilobar or intralobar. They can, the perilobar are associated with overgrowth syndromes and the intralobar are associated with Wagner syndrome, right? Now, we have had two patients that I can remember where these patients had multiple lesions and we had to decide whether this was a Wilms tumor or a nephrogenic rest. We followed them up for quite some time with ultrasound after the initial this thing, and I think one more MR we had. But if you have a spherical or exophytic appearance and size larger than 1.75 centimeters, it favors Wilms tumor, but that does not always work. This is the patient. You can see there are multiple hypodensities here, right? So in case you're following up these patients now, you can always do a plain MRI or an ultrasound. We don't need to do a CT. The initial imaging was done with CT because one lesion was only detected on ultrasound initially, and it was supposed to be a Wilms tumor, but this patient was followed up. The size didn't change, but you can see this is more than 1.75 centimeters, but it can be very, very tricky. So this is one of the places where we come and get stuck. Follow-up of Wilms tumor or follow-up of any tumor is something that we do on basically with the predefined protocols, and CT chest is almost always part of the protocol. So why do we not do CT for the pelvis? Right? Because wherever something is surrounded by bone on all sides, like skull or spinal cord or pelvis, CT does not have the level of soft tissue discrimination or the ability to give you the fine detail in soft tissue that MR does. So here is a patient, I think only 2.5 years old. There was this soft tissue lesion, right, showing very heterogeneous signal in relation to the right pelvic side wall. This is the obturator internus muscle here. You can see this muscle is replaced by the tumor, but that is not the only thing. As I go down, now the surgeon will ask me, is the sphincter complex involved or not? And here I can see the external sphincter, the internal sphincter, the intersphincteric space very nicely. I can see the tumor going up anteriorly almost to the bulb of the penis, to the root of the penis. It is touching the prostate over here. It is touching the lateral pelvic side wall. So I can give all this information on MRI, right? So the level of soft tissue discrimination in the pelvis of MRI is fantastic. That's the urinary bladder, the urethra. You can see all these things and you can give the relationship to the surgeon exactly. So when I have no option and in places where respiratory motion is lower, so in pelvis, the abdomen will tend to move less than the liver, right? Because the thoracic excursion in the pelvis will be limited as compared. So we get relatively better images, but that's not the only reason that we use MRI in the pelvis. It is also A, radiation, B, superb soft tissue detail. And the third thing is we generally get better images where respiratory motion is less. This was an Ewing sarcoma. Just a little bit about the mediastinum. So this is called the ITMIC classification, the International Thymoma Malignancy Interest Group. They divide the mediastinum into three. One is the prevascular space, anything anterior to the aorta or the heart. One is the middle mediastinum, which contains the heart. One is the posterior, which is anything posterior to a line drawn 1 centimeter behind the vertebra. So these are the three compartments. In the anterior compartment, you have the 4 T's: thymic tumors, terrible lymphomas, teratomas, which are germ cell tumors, and thyroid. So thyroid is generally not a big deal for us in pediatric imaging. What we tend to get over here is basically thymic lymphomas, other lymphomas, and germ cell tumors. This is on the X-ray. So not a lot of interest here for X-rays, but in case there is a controversy about anterior, middle, and posterior mediastinum, just to show you that on X-rays, the Felsen classification was different. But this is the classification for cross-sectional imaging, and this is the classification that we should use. It's called the ITMIC classification. So here is a patient who has a very, very homogeneous looking tumor, right? It is not narrowing anything. It is not closing anything off. You just see how big the tumor is, yet the SVC is going merrily through it. And these kind of tumors are very characteristic, where the tumors engulf and encase, but do not compress or close off for lymphomas. And we did a biopsy at the same setting. This turned out to be a B-cell lymphoma. When you get more heterogeneous lesions like this with calcium and areas of fat, you are dealing with a germ cell tumor. Germ cell tumors are almost always seen in males. And in this patient, you see the size of the tumor is almost the same, but you see the level of collateral formation because the tumor has closed off the superior vena cava. So this patient has got multiple collaterals in the anterior abdominal wall. So we talked about neuroblastomas. This is a patient who has a big mass, right? Where do you think the epicenter of the mass is? Somewhere here. So we draw a circle around the mass. We see the epicenter is somewhere here. Over here, to have a lesion of this sort with calcification within, the two main differential diagnoses would be a round cell tumor and a lymphoma, right? But whenever we see calcification, we never ever get calcification in an untreated lymphoma. So that is one thing that should help you to narrow your differential diagnosis, that we never get calcification in an untreated lymphoma. The other thing is there is a lot of involvement of the bone over here of this patient. This patient actually turned out to have a neuroblastoma. And we did talk about imaging defined risk factors. Another place where we always go for an MRI. So that was a review scan from outside. But if we ever thought that we had to do an imaging for a posterior mediastinal mass, we would always go for an MRI. And in this case, you can see there is a posterior mediastinal mass with ill-defined margins, some heterogeneous attenuation, and is extending into the neural foramen over here. And this is again an IDRF. This patient also had a neuroblastoma. So this is a 2.5-year-old female. If we got the same thing in a 10-year-old patient, right, in a posterior mediastinal mass, then we would think of a ganglion cell tumor, but we would not think of a neuroblastoma. We would probably think of one of the ganglioneuroblastomas or a ganglioneuroma. And one of the characteristic things with these tumors is they have this very oblong appearance. They extend over length of more than 3 vertebral bodies, and you can almost then certainly make a diagnosis of a ganglion cell tumor. In imaging of bone sarcomas, MRI is again the modality of choice. CT has no role. After a plain X-ray, the other thing to do is an MRI. So what we do is we characterize the primary bone lesion. We see whether there are any skip lesions. Where is the neurovascular bundle? Is it involved or not? Is it in one compartment, more than one compartment? Is there joint invasion or not? Generally, a CT chest is done along with to look at lung mets, and a bone scan or a PET is done. If a PET is done, we don't do a CT chest separately. And of course, then we do the standard post-treatment imaging. So unfortunately, after diagnosis, staging and follow-up, sometimes we have to deal with complications. So you can have opportunistic infections. You can have patients who present with sinus thrombosis. We get less and less of these nowadays. We have other drug-induced complications, especially the TK inhibitors can sometimes cause them. We can get radiation-induced changes in patients, and we can get things like graft versus host disease and post-transplant lymphoproliferative disorders, PTLDs, which are less common in children, though we have seen graft versus host disease. This is a patient. So on a plain scan, you can see when the sinus looks hyperdense like this is what sinus thrombosis looks like. This is a patient, I think, who had cyclophosphamide-induced cystitis. This patient was in induction, I think, had a febrile neutropenia. And then you can see these multiple nodular lesions with marginal haze. So this is quite suggestive of a fungal infection. Most of the time in our institute, for febrile neutropenia, the workup is a plain CT of the chest. And again, we do a very low dose CT of the chest. We do not give contrast to these patients. We just look for lung lesions like this and see if we can characterize them as bacterial or fungal or viral. They look different slightly. We are actually doing a study on this right now to see whether we can find out what the etiology was. So in conclusion, cross-sectional imaging has provided us with a unique option to look closely at our parents and decipher what ails them in a very non-invasive way. MRI is the modality of choice for CNS, head and neck, pelvis, and musculoskeletal lesions. CT is preferred by most people for lung and anterior mediastinal lesions. Either of them may be used for solid abdominal organs. However, a lot of surgeons, before they go in, they prefer to get at least a 2-phase CT prior to a major surgical resection. Thank you so much for your attention, and that's all I have for you. I'll be happy to take any questions.
Thank you very much, Samar, for an excellent talk. May I request Dr. Mehta to please give
Yes.
give us expert comments?
Thank you, Dr. Samar. It was very interesting, very well put out, very well thought out, uh, very well curated talk. Because, as you rightly said, this talk is not for radiologists. It just brings about the importance of interaction between the clinician, uh, be it a medical specialist or a surgeon, and the radiologist reporting the scan. And this kind of communication is extremely important, and therefore it's extremely important for the clinicians to understand where does CT play a role and where does an MRI play a role. And both can be complementary at times. So there would be times when you would end up doing both a CT and an MRI. A few words about, as rightly pointed out earlier, the developments in radiology. As pointed out earlier, it has been the most rapidly growing specialty. When we started, ultrasound had just barely come in. And from there, that day to now, one can kind of visualize the entire human body in 3 dimensions in various ways that we choose to, with various contrast resolution by various modalities. As far as the thrombus, which Dr. Samar rightly raised about differentiation between a bland thrombus and a tumor thrombus, a relatively newer technique or technology of spectral imaging can play a role. These are more or less standard everywhere. And I would strongly recommend the clinicians to be aware of it and ask for it from the radiologist. Because in these tricky situations, it can land up giving you the answer unambiguously. Spectral imaging is something which is done routinely, and if you see your PAC system, there'll always be an iodine image there. Now that imaging, which highlights the iodine and suppresses the water, gives you a much better idea of the degree of enhancement in any particular region. As far as development in MRI goes, MRI is still limited, as Dr. Samar pointed out, by its inability in most cases to give a volumetric data which can then be processed in a three-dimensional manner. However, again, in MRI, there are more and more sequences and development happening in obtaining three-dimensional sequences. The difference being that in routine MRI, in axial sequences, there's always a gap between the two slices. Now, with increasing 3D, without any gap, it's almost equally amenable to 3D reconstructions as CT is, of course. This still has its limitations, but one sees that in future, one would have more or less 3D MRI images as a routine. Again, as far as artificial intelligence is concerned, it's going to affect all of us in all fields of life. But first and foremost would be its effect on radiology and imaging, not just in terms of ability to do things more systematically by AI, but also in terms of automatically detecting the progress of a lesion. So it's going to play increasingly important role in follow-up studies. You already have software available both on CT and on MRI, where something like, for example, the lung lesions or metastatic lesions can automatically be picked up on follow-up, and their dimensions given, they can be identified, any change in morphology can be identified, as well as it'll give you either a doubling time or a reduction curve. So that is going to come in more and more, and I think all of us in all fields should be prepared for it to come on and ride the wave rather than give way to it. One last thing, no matter where the technology goes, X-rays, plain, simple, routine X-rays, still play a role in the initial assessment. And in some cases where CT is not possible, or they can, at least for chest, be used as a follow-up for tracing or picking up metastasis. So yes, no matter, on one hand, the technology goes fast and rapidly, almost outracing our ability to keep up with it. But at the same time, we should not lose, our feet should remain on the ground and not lose sight of the basics and get carried away with the radiology. Thank you very much, everyone. Thank you, Dr. Samar, for a wonderful lecture. Thank you, Dr. Anupam, for giving me the pleasure of being here. Thank you.
Thank you very much, sir. Dr. Mukesh Thankar, will you please take over? Dr. Mukesh?
Sir.
Please, yeah, please take over.
Sir. So, Dr. Lalit, would you like to say something? We would not talk to you in the beginning of the session.
Sorry, I was a little held up, and excellent eye-opener for us, for a general pediatrician. So many things are going in radiology over the time. Sir, Dr. Samarji, एक simple सी चीज for our pediatrician general. What is the excellent modality for NCS, neurocystic cirrhosis, which we commonly find a practical problem? CT कराएं, MRI कराएं. They say tutorial will be missed. So what is your ultimate summary message for us? Of course, this was not the topic for today's discussion. I'm just asking for this.
For NCC?
Yes, neurocystic cirrhosis.
तो देखो, most of the time तो ऐसा होता है कि when it depends on what is your practice, right? If the person came with, if a child came with seizures to Gangaram, probably they would first have an MRI. If they were to have
sir, ideal बताओ sir.
तो आइडियल तो सीटी पे आराम से दिख जाता है, राइट?
Also the confused,
NCCT और CCT sir.
Sir, NCCT pe you can easily see the scolex and the cysticercus. The problem is once it is a little older, when it goes into the second or third stage, then you can, and you're not able to see the scolex, then you may have a problem deciding between NCC and tuberculoma. वही आपकी जो हमेशा होती है कि NCCA के tuberculoma, NCCA के
We are
tuberculoma.
always caught up with things.
ठीक है ना सर? तो जो फर्स्ट सीजर के बाद एकदम आपके पास आता है या जो फ्रेश एनसीसी होता है उसमें तो कोई प्रॉब्लम नहीं होती, दोनों में पिकअप हो जाता है. पर अदरवाइज आउट ऑफ द टू आई वुड देन प्रेफर टू डू एन एमआरआई.
So it's like preferably is MRI.
Yes.
If not available, NCCT or CCT, sir.
So whenever a patient with a seizure comes and there is no MRI available, I always like to get a CCT.
CCT.
Because sometimes you can see small tuberculomas which are hidden by edema, so they enhance much better. You will give you an idea about the underlying lesion. If MRI is not available, then I would like to do a CCT.
Great, sir. Great, sir. Dr. Pankaj Garg is also with us, sir. Would you like to add some comments? Or Dr. Pankaj Garg? Right, sir. Sir, I have a question. So whenever we have a malignancy, say we have a Wilms tumor, or whenever we are going to do a neuro imaging for a metastasis in chest, so what would be your take on that? NCCT, CCT, or even MRI is coming up for the chest?
I don't think anybody would yet recommend MRI for the lung. I don't think it is at that stage yet. The thing is, if you are already doing a CECT, when we are already giving contrast to the patient, then we run the chest with the contrast, right? Because the contrast has already been given to the patient. But if we have to evaluate only for metastasis in the lungs, then we do a plain CT. It is
Plain
good.
CT. Great. Great, sir. Right, sir. So, Dr. Alok, sir, something from your end? Dr. Alok, Dr. Pankaj Garg? All right.
Sir, can I ask Dr. Mehta something?
All right,
Yes,
sir.
most certainly, Dr. Sam.
We don't have a spectral CT, sir. We came very close to buying one. So are you doing spectral scans for all patients? Or do you have to decide beforehand that I have to do spectral for
we
this?
are doing, just a second. We have spectral CT and we are doing it in selected cases.
In selected
Now
cases.
in spectral
beforehand.
CT, now there are two things happening in spectral CT. One is that you decide before the event whether you want spectral data.
Yeah.
Other is one of the vendors has come up with where spectral is always on.
So that's the one we were looking at. Unfortunately, we didn't get it this time. Maybe next time.
Yeah, it's too expensive in any case. They are always on CT. So it's not really worth that much. But yes, in all malignancy cases, suspected malignancy cases, we do run the spectral image. For example, any HCC protocol or any liver protocol for that matter, our arterial would be without spectral. Our venous space we run, where we run the whole abdomen, would be with spectral imaging. And the advantages there are distinct because its enhancement is so much easier to pick up and document. And then you can really play around with the contrast. You can play around with the elements. You can have the graphic data imposed on it. So yes, so in certain cases, you want to pick up fat density within the lesion, it helps. Now, whether it is cost effective in terms of how many patients out of 100 it would really be helpful,
useful,
and whether that is worth the cost, the extra cost involved, is a very, very debatable question and a very institution specific question.
Thank you.
Sir, one question I have for both the eminent faculties. What role of artificial intelligence you see in the field of radiology, especially in the cross-sectional imaging? Can it replace the human intelligence in the future, or it will just say what you...
Dr. Samar, you want to take it first or should I take it first?
Okay, I'll take it first, sir.
Yeah.
Since you are more experienced, you can fill in the lacunae which I leave behind, sir. So I don't think, sir, that there will be a replacement, right? So there will be
Value addition.
radiologists use artificial intelligence to give you a better report, maybe a
Better.
faster report.
So value addition.
Yes, because there is no, I don't think, forget the legal aspect. Sometimes we have been part of a lot of studies, and sometimes it makes such horrendous mistakes that for no reason, because nobody actually understands, right, how this black box is working. It is just Dr. Neerav and me training it, and I called it NCC, he called it tuberculoma. So it just looks at the data and says, okay, this is like this, so it should be a tuberculoma. That is what it does. It is not analyzing anything else. It is analyzing the data that way. The other thing is radiomics, where we use our eyes. That uses a lot of the mathematical data to tell you things about, like I said, it can sometimes look at lesions and tell you that this is a mutated MYC mutated lesion. This looks like a BRAF mutated lesion, because people are training it. So like BRAF mutated tumors will look like this in a particular organ. It will keep seeing that. Then after around 10,000 of that, it will tell you that this is or this is not. So that is another aspect. Again, it will help us. I don't think it can replace us. Sir?
Thank you. Thank you.
Yeah, I agree with Dr. Samar. One thing, the way it is, the speed with which it is going, and the way it is going, the future really is unpredictable. Taking your question a step further, I mean, how do we know it's not going to take over mankind? How do we know it's not going to replace the human brain? Which it can't as of now. But then 2 decades back, who had thought of AI being where it is? So it's changing rapidly. Things are changing rapidly. As of now, no, AI is not going to replace the radiologist. It is still pattern recognition based on what it is trained for and who it is trained by. And it is basically comes down to data crunching, whereas a human brain is much more than data crunching. So yes, radiologists will remain. Maybe, just maybe, you might need one radiologist where 4 exist today to oversee. But if you look at something like biochemistry or microbiology, where everything is automated and the microbiologist is just needed for signatures and for process control and quality control. So that aspect can never be taken away from the radiologist. So yes, you will still need a radiologist. And where AI will play, it will make radiologists more efficient. It will make more accurate. It will benefit the clinicians by, as Dr. Samar said, faster turnaround time, perhaps more accuracy as long as it is overseen by a radiologist. The ability to pick up things which the human eye does not see or does not recognize. So yes, it is going to play an increasing role, but it is not going to make a radiologist extinct.
So thank you, sir. Thank you, Mehta sir. Thank you, Samar. Thank you, Anupam sir, the AOP Delhi, Dr. Alok sir, Dr. Mukesh. I had to take your permission. Okay, Mukesh, can I sign off?
Sir, it's our
Thank you.
pleasure.
Thank you, sir. Thank you for the invite.
Thank you.
for
Thank
having
you.
Thank you for the invitation. Thank you.
Sir, Lalit sir, would you like to say something, sir, before we close, sir?
Hello?
I think is Lalit sir, are you there?
Actually, I'm here. I'm just moving around. Actually, we had a very nice interaction with radiology. I think we should always need it, whether for ultrasound, X-rays, scanning, and so many things to learn about. This is always helpful for us. And this topic was today only on the solid tumors. I think we can have on discussions on infectious diseases also and other components in relation to ultrasound, X-ray, apart from the solid tumors. We can have a session on the routine infectious diseases in relation to like pediatric basic X-rays, pediatric basic ultrasound. That will also give us another input to the various conditions which we commonly come across. Today's discussion was on solid tumors. We can have an excellent presentation by Dr. Samarjit and very nice inputs by the esteemed faculty. Really wonderful session. Thank you very much, sir.
Thank you.
Thank you very much,
Thank
sir,
you.
and good night, everybody.